Thanks very much for the invitation, and I think it's not an understatement to say that my entire career is a function of the support that we got from the HRB, and I'm very grateful. I was actually a CSA at the same time as Louise, and really my work is around a niche disease, motor neuron disease, or amyotrophic lateral sclerosis. I'm going to talk a little bit about that. But one of the things that people say, and one of the sort of negative things that happen about Ireland, we're very good at bringing ourselves down about being a small community and limited funding, jealous of the funding that you get in Canada. But we have very distinct natural resources in Ireland, and I think that we don't play to our strengths here. One of the things is that we're an island, and being an island makes us unique in many different ways. We have a stable population structure, quite different to the rest of Europe actually, and also the United States and Canada. We have a high level of interconnectivity, and we still do, even though our society is changing. Everybody knows everybody else. It's actually quite difficult to get lost developed. It's impossible to have an affair in Ireland. We have large clinical, I haven't tried, but we have large clinical cohorts and centres of excellence. It's a disadvantage in a way because we had underinvestment in our health services, but that did allow a sort of organic kind of Irish solution, which has led to organically driven centres of excellence, which we can work to our advantage. We also have very motivated clinicians, and I think today we'll demonstrate that. And because we had a tradition in my generation anyway of emigrating, I emigrated in 1986. I was the last person to leave Dunleary, so I turned out the lights. Many of us came back then, but people trained abroad and developed a very strong training and research methodology. So many of the people of my generation are very motivated and have very strong track records. We also have strong patient advocacy groups, different from other countries as well. So these are the ideal circumstances to conduct population-based research, and I don't think we've done enough of this in Ireland. Now, my research area is in a condition called motor neuron disease, or ALS, and these are some of the famous people who've had ALS, Nicky McFadden and Michael Fitzpatrick and Colin Murray being the three Irish people, all of whom I looked after. And so I've done most of my work on ALS over the last 20 or 25 years, and a lot of it is centred around the concept of a population-based structure, and it's really been around epidemiology. And the HRB has funded this work for the last 15 or 20 years or so. And out of the money that the HRB has given us, and me and my group, and from my CSA in 2007 and then renewed in 2012, we've been able to leverage that. We've been able to leverage funding from other sources, including a seven framework project, which completed a couple of years ago, and more recently money from the CDC in the US. So one of the things that we have been doing, just some highlights over the last 10 or 15 years, we know a lot about the incidence and prevalence of motor neuron disease in Ireland, and this is just a typical graph that we show, which we published years ago in 2008 now, again funded by the HRB, and more recently by a fellow, James Rooney, who works with me, who's a HRB fellow, looking at whether there's clustering of ALS and motor neuron disease in Ireland, and actually showing not any hotspots, but actually a cold spot in Kilkenny. So there's less motor neuron disease in Kilkenny than there is in the rest of Ireland, which is kind of weird. We have some theories as to why that is. That got published last year. So out of that, we also we've leveraged our interest and our expertise in population-based registers with those of like-minded individuals in different parts of Europe. So we set up a group called EURALS, European ALS Research, and we've been thinking about population-based registers over many years, and out of that came many other studies, including interest in admixed populations, or populations of different genetic origin, particularly in Cuba, which is where I've done a lot of work. I'm not at the funeral. But what we showed was that the frequency of ALS was different in different population subgroups, which related to the genetic substructure of the population, which is the first time that was ever demonstrated. We published that in 2009. The HRB helped to fund that project. And out of that, we were able to build a new network, which I've just started in Latin America, with 3 countries in Latin America, Cuba, Uruguay, and Chile. Nothing to do with the weather in those places. But that's funded by the Centre for Disease Control. It's the first time the CDC in the US has ever funded a project in Cuba. So that's a direct consequence if you trace it back to the HRB. And that's a really important study, because it's a study where we'll be able to identify and unpick the relationship between genetic factors and environmental factors as causative factors in neurodegeneration with ALS or motor neuron disease as a model disease. We've also been, I've been a phenotyper all my life. I've been a splitter rather than a lumper. I like examining patients. I like thinking about patients, and I like thinking about subtle variations in patients. I've been doing this all my life. The HRB funded my work on this over the years, and out of this we've got funding from the United States, the ALS Association, also the UK, the Motor Neuron Disease Association in the UK, and smaller niche charities. And we've been looking at the frequency of non-motor changes in motor neuron disease, or thinking changes that occur in motor neuron disease. We're leaders in this field now. We're seen and recognised internationally as one of the key researchers in this area, the frequency and changes of changes that occur within the brain, and subgrouping the brain then, subgrouping these changes and looking at the genetic factors and also the behavioural changes and the effects on caregivers of these sorts of behavioural changes, and that's work that's ongoing at the moment. But what it really shows is that these neurodegenerative diseases, and motor neuron disease being an example of that, are heterogeneous, and this heterogeneity has really interfered with our abilities to engage properly with clinical trials. And what we need to do now is to separate these subgroups of patients into more clinically definable groups and other ways of defining these subgroups, so that we can engage in more effective clinical trials. And we've published quite a bit on that as well. Some of these subgroups are also a function of genomics, and the HRB has also funded a lot of genomics research for us, and that allowed us again to leverage our work through funding from the Science Foundation in Ireland and also from international charities. And some of the work that we've been doing in this is genome-wide association studies, looking at the common variants that might be associated with these neurodegenerative diseases. And we're part of an international genome-wide association consortium, published many papers. This is the most recent one that's just come out in Nature Genetics, showing using 14,000 patients and 26,000 controls, some new sites that we can interrogate to identify possible pathways that lead to the generation of this disease. We've also, as I'm a phenotyper, I've been looking at the relationship between motor neuron disease and other diseases, and one of my observations clinically, which the HRB fund as well, was an apparent epidemiologic association between motor neuron disease and ALS and neuropsychiatric disease. This is heretical when we published this paper in the Annals of Neurology in 2013. It was an epidemiologic study, but we subsequently did a combined genome-wide association study, which is coming out now this month in Nature Communications, showing that motor neuron disease, or ALS, shares 14% of its genetic susceptibility with schizophrenia. So that's actually quite heretical and really exciting, because it opens up a whole new set of thinking and discussion around what's happening in the brain in motor neuron disease and the network disruption that occurs that correlates with that's associated with schizophrenia. One of the things that I've been interested in all my life is the idea of pedigrees and the idea of an island communication that is linked with itself, that we have families that are structurally quite large and that are linked to one another in ways that we mightn't necessarily care to recognise. And we've received funding from the HRB and other agencies to look at this. And what we've done is we've been able to, both epidemiologically but also genetically, using something called identity by descent, which is mathematical modelling, generate very large superfamilies. And we can start phenotyping these superfamilies and looking at not only the occurrence of motor neuron disease within these families, and we've shown that the frequency of familial motor neuron disease in Ireland is not 5%, which is written in the literature, but actually 20%. But not only that, but there are other diseases lurking within these families which occur with a greater frequency than we might expect. I mentioned schizophrenia, but there are others as well. So we have DNA on these family members that have arrows, and we're part of a large consortium called Project Mine, which is mining the genetics of motor neuron disease. It's the biggest crowd-funded project in the world of its kind. We're going to genome sequence 22,000 500 genomes, of which 16,000 will be patients and 7,000 will be controls. We're part of this. We've already raised 64% of what we wanted to raise. We're going to do 1,700 patients and 300 controls, and we're about halfway there at the moment. That wouldn't have happened without the HRB. What all this is doing is allowing us to engage in conceptual thinking around what is disease and what is the nature of the disease and how should we look at ways of finding new treatments. So if we have new concepts in disease, we have new concepts in drug development, and this is the model. This is sort of a summary of what I do. As Graham said, it's multidisciplinary, but the ultimate aim is to develop new cohorts that we can then integrate into the clinical trials that we're underway with Clinical Trial Unit in Beaumont, which we fund. We've 4 full-time clinical trial researchers in Beaumont that do motor neuron disease research. But also we need to translate what we do into health services, and I think Dr. Lee's talk this morning really focused our minds in that regard. And I feel very strongly that the work that we do should also inform how we deliver our health services, and the HRB and JPND, Joint Programme Neurodegeneration, and also some of the niche organisations outside of Ireland have supported us in our work in this regard. One of the studies that we're doing is looking at the patient journey from pre-diagnosis right through to death. So this is just some data that was shown. This is a horribly inefficient way by which we diagnose motor neuron disease, by the time it takes for people to come to clinic. On average, people see 4 healthcare professionals, and it takes 19 months to come to a multidisciplinary clinic. So we need to change that, but in order to change it, we need to understand why that's happening. Why should you come to a multidisciplinary clinic? Because it's better, and we've shown this got published last year, I think, but we published a similar study actually 13 years ago, showing that if you attend a multidisciplinary clinic and that everybody's in the clinic, you do better. And so this is a survival curve. The top line is people who come to us, and the bottom line, there are 3 lines there actually. The middle line is people who go to my colleague Colette Donaghy in Belfast. She's an ALS doctor, but she doesn't have a multidisciplinary one-stop shop, which we do. And the third line, which is hard to see, is people who don't come to either type of clinic. So multidisciplinary clinics improve survival, and this is very strong evidence to support this. I'm surprised. It's a pity the minister is gone actually, because I'd like to show him the slide. The work that I've done, obviously, I'm presenting it, but the work has been done by the team. The people in red in this slide are the people who are funded from the HRB. So these are people that I recruited, that have worked with me over the years, that have been funded by the HRB and who have gone on to develop their own careers in this area. We also have many international collaborations, because I think Louise showed as well that we are a small country. We can deliver very good science, but we live in a much bigger, wider environment, and it's very important to collaborate internationally. The funding that I've got from the HRB has allowed me to leverage funding from many different sources. I'm not quite as rich as Louise, but I added up that we've, in total over the last 20 years, I've received about 3 million from the HRB, and we've raised in Ireland about 13 million from the various different funding agencies that are noted there. Thank you very much.